Welcome everyone. It's a pleasure to kick off the day 2 of our workshop. I'm going to speak about creating global resources to support variant classification. And I did want to start things off with a story. And in fact, I'll give 2 stories at the beginning of this lecture, because I think it really underscores why it's important, the work that we do in variant classification. And this is a story written in the Wall Street Journal about a girl who underwent genetic testing. Her name was Esme Savoy, and she was born in 2011, was affected by hypotonia, failure to thrive, seizures, had cardiac arrest, and she's had a number of genetic tests over her lifetime, multiple tests, and in fact multiple diagnoses as to what the cause of her condition was. Initially, she was told that she had an early infantile epileptic encephalopathy due to a PCDH19 variant. And in fact, the family started an online support group for parents of children with variants in that gene. She raised money. They were highly engaged for 2 years, but then noticed that their child wasn't like other kids with that same gene variant. She then, in 2015, that variant was reclassified and actually ruled out as the cause of her disease. She then had exome sequencing. They found another variant in a different gene. It was classified as uncertain significance, but the family, was convinced that that probably was the cause. They stopped the other foundation and started a new foundation on SCN8A to stimulate research in that area. Then a year later, that exome was reinterpreted. The variant was still a VUS, but then they found other variants that they thought were pathogenic and likely pathogenic and were probably the cause of disease. So you can see what's going on here. A constant evolution of knowledge, of opinions about a variance, and in fact, over the course of this time period, 10 years, the standards that we've used to classify variants has significantly changed, and that has clearly impacted this family. I also want to share another story, and this one is more about data sharing. Over 6 years ago now, my lab detected a PTPN11 variant in a fetus with increased nuchal translucency seen on ultrasound. That variant had been observed in an Ashkenazi Jewish patient with Noonan syndrome and was reported by a very well-respected lab as pathogenic. I had tried to get access to a research data set of individuals of the same background, so I could determine the allele frequency, which is important in interpreting variants, but was denied access. So we did the best we could with the evidence we had. We reported it as likely pathogenic, and the couple terminated that pregnancy. Later, we found out the variant had a high allele frequency in the Ashkenazi Jewish population, in fact, from the very data set that I was denied access to, and that variant was benign, and a terminated pregnancy could have been avoided. The good news is that 6 years later, we now have other resources. We've come a long way. We have the ClinVar database that Melissa's going to tell you about today, working in partnership with ClinGen, and we also have the NOMAD database, sharing allele frequencies from many populations around the globe. And in fact, a very similar story came about just now a few years ago, where a couple had prenatal genetic testing, and prompted by an increased nuchal translucency measurement in the back of the neck, like the other case, they had genetic testing that revealed a variant of uncertain significance. By then, we had ClinVar. I had submitted that variant from my laboratory into ClinVar, and so had another lab, but we both called it uncertain significance. But the family was savvy. They reached out and said, our fetus has this variant. Is there anything else you can tell us? And prompted by the question, we looked into the evidence that we had in the lab on this variant from the case that we tested. I also reached out to GeneDx that had also seen the variant. We aggregated our data together and were able to reclassify that variant with all of the evidence in hand as likely benign. And that couple continued their pregnancy as a result and gave birth to a healthy baby boy. So it's a very different story, and a story that's really benefited from data sharing, which is critical in the field of variant classification, where we deal with very rare variants and we really need to share data globally. Now those variants are updated in ClinVar. They're both submissions are likely benign as a result of this new knowledge. So that brings me to talking about the variant efforts within ClinGen. As Sharon introduced at the start of this workshop, ClinGen stands for the Clinical Genome Resource, and we're really creating authoritative central resources to define the clinical relevance of genes and variants for use in medicine and research. And this program is funded by multiple grants, as Sharon had mentioned, but it really thrives because there's so much participation from the community. As you can see these numbers at the bottom, 1,557 investigators across 36 countries are involved in our working groups and expert panels, and that's really what helps us generate all of the results that we generate. Over here on this infographic, we start with data from many sources, and we curate that data to answer critical questions. Gene disease validity that Erin Riggs talked to you about, variant pathogenicity that I and Stephen and Melissa are going to talk about, and we have other areas of curation, dosage sensitivity, and clinical actionability as well. We really generate this resource to disseminate to the community in the hopes of ultimately improving patient care. So I get asked often, what is the difference between ClinGen and ClinVar? So I made this simple graphic to illustrate the key differences. ClinGen is really a consortium of people sharing data, developing standards, and curating knowledge, whereas ClinVar is a database supported by NCBI that is a centralized place for submitters to share their variant knowledge. We also have a database for gene-level knowledge in ClinGen that's on the clinicalgenome.org website. So it's really, ClinGen is a consortium of people, ClinVar is a database, although a very important one, and a lot of work to maintain, as you'll hear from Melissa. So I'm going to talk a bit about the overall strategies we take to support variant pathogenicity. I'm going to leave the details of how we do that to Stephen in the next lecture. But it does start with common standards, and Stephen in the next lecture is going to talk at length about those standards that we use for variant classification. And it starts with the Acmg Framework that we developed now 5 years ago, which has been adopted worldwide and was the first detailed framework for how to apply evidence to variants, and Stephen will describe that in depth. And he'll also talk about the sequence variant interpretation work group that ClinGen has launched to evolve those standards. And all of the work of the sequence variant interpretation work group that has been evolving these standards is on the ClinGen website on our SVI webpage. You can see here a list of the different codes that we've launched additional guidance for, as well as publications when they've been published. Some of them are just white papers. So all of that information is on our website, and Stephen's going to give lots of great detail on that. I'm now going to move on to another critical step in our multi-pronged approach to variant classification, which is the public sharing of variant classifications in ClinVar. This creates transparency to our work. It allows us to share our evidence and rationale for variant classifications, and it effectively crowdsources the work. And I will just point out as a specific example, since we're working here with the H3Africa group, that this is critical for every variant you will classify that you observe in African individuals with rare disease or with any disease. The majority of those variants you will find are variants of uncertain significance. Two key resources that are needed, as Anne O'Donnell-Luria talked about in the NOMAD talk, it's critical that we have population frequency data. And that's population frequency data both from matched populations, so if you have individuals of African descent, to also have population data of African descent. And sometimes the variant's high enough in those populations, a matched population, to rule it out and call it benign. However, sometimes it requires a different population of distinct ancestry to call a variant benign. And in the same way that individuals of Caucasian descent benefit from African data, African individuals benefit from Caucasian data, and so is true of all the different populations across our globe. So that's one reason that it's really critical that we all share our genomic data to identify allele frequencies that can help us rule out variation. However, when we get to the variation that's rare in all populations, this is where it's really critical that we share case-level data from affected individuals and we share the work of variant classification. Now, Melissa's going to talk to you at length about ClinVar, but I do want to at least introduce the database because it's a critical database for us to share variant classifications from all around the world. And it's really become a global resource. There are over 1,790 submitters from 80 countries that already have submitted to ClinVar. And one thing just to point out, there are about 89% of the data is from clinical labs. In fact, 84% of the data is from the top 20 submitters, most of which are clinical labs, and in fact 14 of those are commercial labs. And I point that out because it really underscores the goodwill in our community of these commercial laboratories. Even though they have for-profit businesses, they are willing to share their data in a pre-competitive space. And it underscores their belief that this is critical to the process, to have good services, to be able to crowdsource the effort, the enormous amount of effort that goes into variant classification. Now, each country needs to develop its own strategy in terms of how to encourage submissions from the laboratories in its own country. So this is some of the efforts we've done in the US, written up a document documenting the benefits of sharing variant classifications and evidence with ClinVar. We've worked with medical professional societies who have come out with guidance and policies around the importance of data sharing. And many of those arguments are very clear. Sharing this data improves variant classification, allows us to generate a shared evidence base. It enables standardization and quality control across this variant classification activities. In many cases, it's now addressing evolving regulatory and medical standards. And it's also, interestingly, some of us hadn't realized this at the start, but we have to keep our reports up to date. This knowledge changes. And by submitting to ClinVar, it's a place that clinicians can go to find out our current interpretation of a variant. So that also is quite useful. In the US, because a lot of the business strategies are controlled by reimbursement and payment for genetic tests, we launched what we call the ClinGen Lab List. And this is a list of labs that meet a minimum set of requirements for data sharing to support quality assurance in this field. And we launched this list to both publicly recognize labs that share their data and incentivize others to do so as well, but also to provide a list of clinical labs to hospitals, healthcare providers, and insurers who pay the bills, so that they have a list of labs that they can order from or reimburse that they know are meeting this standard. And that the launch of this list was critical in getting some of the labs that hadn't yet pushed their way to data sharing to really embrace that as payment seeks to use this list to decide who to reimburse for testing. So there are different strategies that each country is using. Because of the strategies we've used in the US, it's no surprise that the vast majority of data in ClinVar today is from the US. But I took out the US data and made another graph here to look at the rest of the countries. There are 79 other countries submitting to ClinVar, and some of them submitting a lot of data. I have also highlighted here the data that's so far been submitted from African countries, which is over 1,000 variants from 5 different countries. So you're getting started, but obviously much work to be done, and we're delighted to be able to help you all get there because it is work to submit to ClinVar. And there's different strategies being rolled out in different countries. I did want to share here the strategy in Australia. They have launched a variant sharing platform called Sharient that derives from the name sharing variants, obviously. But the way this works is that they have separate instances of this database in clinical labs around the country. It allows them to communicate and share expertise and information, resolve variant discrepancies, but it also enables them to support the sharing of that information to ClinVar by acting as a central administration node to facilitate the sharing so that every clinical lab doesn't have to manage that on their own. So I think these are really important strategies that countries develop. And I should mention that it is critical that each country think about the infrastructure that's needed. So every lab needs a place to maintain their own variant classifications that may be connected to case level data, and that site can be managed on a daily basis, updating knowledge. ClinVar does not serve that purpose. Labs periodically submit to ClinVar, but they can't do their own curation and knowledge management within ClinVar. You need a separate database for that. I will mention that ClinGen's variant curation interface is a possible solution for labs that don't have their own place to curate variants. Often a lab will also need a place for their case level data. These are the genotypes and phenotypes of individuals who have been subject to genetic testing and interpretation. On the other hand, ClinVar has become the primary database for sharing, comparing, distributing, and accessing variant interpretations with the community. So really encourage sharing with ClinVar. One of the things that's been helpful to different laboratories and countries is differentiating the sharing of variant classifications from case level data. And so we wrote a paper, Points to Consider paper, that was published from both ClinGen, working with the NIH and the Global Alliance for Genomics and Health, to really define the sharing of variant knowledge as something that didn't require consent, was not patient-level information as a result. In addition, the UK has come out with a position statement that's also defining the same principles and helping their country adopt this same strategy in knowledge sharing. That brings me to the question of consent. So as I pointed out from these position statements, consent is not required to share variant interpretations with summarized evidence, but it is required if you want to share more detailed individual level data. And ClinGen actually has videos now in multiple languages that helps explain the difference, where we can talk about summary or aggregate information to support variant classifications that can be shared without consent, as well as what the benefit of providing that consent and be able to share detailed clinical phenotype on a per case basis, still de-identified, but at least more granular, which does sometimes require consent. So now we're going to talk about interlaboratory conflict resolution. This is where we resolve differences in the classifications between laboratories. And one of the things that helps us to do that conflict resolution is by sharing in ClinVar. When we do that, we can look for data where multiple submitters have submitted. So we look at all of the data in ClinVar, and I've plotted it in a pie chart here. First thing you'll notice is that 74% of the variants that have been submitted to ClinVar have actually only come from one submitter. And that underscores just how rare much of the variation that we deal with is when it's only been seen by one laboratory. However, if we look at the 26% that's been submitted by more than one laboratory, a total of 15% of all variants are concordant in their interpretations. They're the exact same classification. About 5% are what we call confidence conflicts. So one lab may have called a variant pathogenic, another lab calls it likely pathogenic. Largely, those aren't significantly meaningful differences. They're usually treated the same clinically. Where we start to care more is when we get into the orange and red zone here. So in orange are about 5% of variants in ClinVar, that have differences that are one lab calling the variant uncertain and another lab calling it benign or likely benign. And while that shouldn't lead to changes in medical management, certainly getting more VUSs on reports does create hassles and sometimes can be misinterpreted. So we do try to resolve those differences. But what we spend most of our time on is the 1% of ClinVar that has what we call medically significant conflicts. And this is where one lab is called a variant pathogenic or likely pathogenic, and another lab is called it VUS, likely benign or benign. Currently in ClinVar, there are a little over 10,000 of those medically significant conflicts. Now, in ClinVar, as Melissa will describe, I think, there's different star levels that represent the level of review that each variant has undergone. Submitters that submit their assertion criteria, so the methods that they use to classify variants, as well as the evidence that supports those variants, get a single star, as opposed to those who don't do that get 0 stars. So we actually usually focus on those assertions that came from 1-star submitters, and in fact you can also designate whether you're a clinical lab or not. And so we usually focus on the discrepancies between clinical labs where we know they're going to have clinical impact, yet these labs are usually taking standardized approaches. So those variants represent a little over 5,000 discrepancies currently in ClinVar, and that's the batch that we're spending most of our time on. So in the first phase of our variant discrepancy resolution efforts, we got 4 labs together and we tested out whether we could resolve our differences. We started with 242 discrepancies, and then we not only had everybody reclassify all of those variants so that we could compare current knowledge, we also looked at why we were different in those variant interpretations. So sometimes it was just because we hadn't yet submitted our most up-to-date interpretation into ClinVar, and that's a key point to keep in mind, is that labs periodically submit to ClinVar for the most part, and so the classifications in ClinVar can be out of date to some extent, so it's always important to look at the date that variant was classified. Now, as Melissa will tell you, they're rolling out API-based submissions, so that may improve over time. Then for another chunk of variants, once current standards of interpretation were applied, that resolved about 1/3 of the variants. For another about 15%, it was differences in how we were using data from public resources like allele frequency data, things like that. And then about 1/3 of the time, we were different because we actually had different underlying evidence that we each had access to. So maybe one lab had segregation data or de novo occurrence observations from their own testing that wasn't published and no one else has access to. And that is really one of the key things of why we submit to ClinVar, is so that we can be alerted when labs have other knowledge that we haven't taken into account. We've now moved on to phases 2 and 3 of this effort, and what you can see here is that in phase 2, and this work was led by Stephen Harrison and Jill Dolinsky, and they took a more streamlined approach, the outlier approach, where they really focused first on having laboratories that were different than the rest of the labs reinterpret the variants first, and in doing so that resolved 63% at the start, and that was a much more efficient process. Phase 3 now involves even more laboratories to really all work together at sharing data and resolving discrepancies. I will say that a lot of our discrepancy resolution is now moving on into our ClinGen expert panels, but an important thing to note is that even when we don't facilitate discrepancy resolution through active interlab efforts, about 24% of variants that were discrepant were resolved simply because the data was transparently accessible in ClinVar. So again, can't underscore enough the importance of sharing data. Now, I'm also part of another program called the All of Us Research Program that's doing some activities very similar to ClinGen in terms of interlab discrepancy resolution, because this program has 3 different genome centers that have 4 clinical labs as part of them. And in order to return results to the participants whose genomes we will sequence, we needed to harmonize all of our variant classifications so that no participant across the program would get different interpretations of the variants. So these were the 4 laboratories: Color, Baylor, University of Washington, and Mass General Brigham LMM. And we first shared all of the variants from the Acmg 59 gene set, which is what we'll be returning results from. That was just under 50,000 variants. And of that data set, about a quarter of the variants were seen in common between the laboratories, and we could compare our interpretations. And when we did that, we had agreement of 99.1%, which is actually quite high, and really underscores how far we've come as a community in getting ourselves to concordance. Now, as I've been remarking on, we don't always agree, and in this case we had 102 variants where we had medically significant differences. So we went about tackling those variants through first round 1 was the outlier approach that I just spoken about for the ClinGen project, as well as stimulating labs that had older classifications to reassess them. And then that resolved 46% of the differences right away. We then tackled with more effort the next 54%. That required all of us to share our rationale for the classifications, what codes we applied, the evidence we had. And through a number of months of work, we were ultimately able to resolve all 102 variants. So a great effort. Now, as this program launches and we start returning results, we're already sequencing, but we haven't quite gotten approval from the FDA to start returning the results. But we will soon. And then we'll continue this process in real time. We actually have a platform built by the Color team where all the results get reported. So if anyone has a differing classification in the system, it will halt you from being able to sign out the case. And then that variant will be triggered to our variant adjudication committee that meets every other week, and we will continue tackling the differences in interpretation. For those variants that we can't tackle within the committee, we will punt them over to our ClinGen expert panels, and that will help us resolve differences in variant classification. Occasionally there's exceptions, variants we're not even sure we want to return, and we'll involve our return results committee in those. So that just gives you an example of really applying the principles of ClinGen for specific projects that really require highly rigorous standards in variant classification. Now, even when we try really hard, we don't always agree with each other in the end, and so we don't actually expect 100% concordance between clinical labs. In fact, the most common reason we differ in our classifications is how we treat functional data. One laboratory director may decide a functional assay is valid and good evidence in support of variant classification, and another lab may say they don't trust it, they don't feel it's been well validated, and they wouldn't apply the same level of evidence or, in fact, any evidence. Those are examples where we can differ in variant classification, and that is one of the reasons that we do engage experts. So resolving the remaining interpretation differences does require expert consensus. So that brings me to the 4th prong, where we build these expert panels so that we can generate these consensus approaches to variant classification. And this is just an example of a variant, which in ClinVar actually has 33 submissions on it, and it spans a whole range of different interpretations, as you can see here. 22 pathogenic, 4 likely pathogenic, 2 variant of uncertain significance, 2 likely benign, and 2 benign. And actually this is in a much better state than it was before we submitted our expert interpretation. But basically, when you have these variants with differences in interpretation, we can bring in our expert panels that can classify these variants, and then using the star system, move these variants up to 3 stars so that the expert panel classifications override the individual submitters, and that's how we can very quickly resolve these differences in interpretation. So to do this work, ClinGen has been forming all of these expert panels. On our website is a page that talks about our expert panels, And right now we have 13 different clinical domain working groups. These are broader disease areas that we support multiple expert panels in. You heard from Aaron Riggs about our gene curation efforts. So we have 32 gene curation expert panels, or GCEPs. But we also then have 37 variant curation expert panels so far, doing a lot of the work that I'm starting to now describe. Now, these expert panels have to operate with experts from around the globe. So it does create challenges for the time zone issue, which we have to deal with. Some of you may be in your pajamas, others late in the evening with a drink in hand, but we make it work. And in fact, we have over 1,500 researchers and clinicians and other experts from around the world that are participating in our expert panels. And that's really what makes them so rigorous, is to have that diversity of opinion and background and data sets that they all bring to the table. So each of the expert panels has to go through a series of steps before they can get approval. First, they identify the leadership of their group and who's going to be a member, and they reach out to all of the experts in the community to participate, define the scope, what disease they're tackling, and what their gene list is. They address conflicts of interest, and then they have to specify their Acmg AMP rules for the genes that are in scope for their group, and specify the different rules. And those have to be reviewed by our sequence variant interpretation work group that Stephen will talk about in the next lecture. They each then have to validate their specified rules, comparing against already classified variants and piloting whether they agree with the classifications, sometimes modifying those rules to finesse them to really getting to a standard that they feel is valid. And then once approved by ClinGen, they can move on to then classifying variants regularly through their working group and submit those to ClinVar. Now, when they do this specification, there are a number of codes that are specific to a disease area or a gene. So, what are the functional domains or hotspots of those genes or proteins? Are there validated functional assays? What's the prevalence and penetrance of that condition? Is there phenotype specificity of it? Pathogenicity mechanisms specific to those genes? These are all aspects of variant classification that are best done with specifications for the particular disease or gene. And just by way of an example, the RASopathy Variant Classification Expert Panel, or VCEP, when they did their work, the final classification of over 60% of the variants that they classified for the RASopathy conditions were impacted by these rule specifications. The good news is that once they made these specifications that were very clear about how to use certain data types, the labs were able to reach 100% concordance for the discrepancy that they reassessed. So it really shows you that doing this process that our expert panels do brings a level of reproducibility and objectiveness to the data analysis that sometimes isn't there when you're having to make a rule set for every gene in the genome. Now, the write-up of the rules from each of those expert panels goes on the Sequence Variant Interpretation Workgroup webpage shown here. Once published, the publications are also linked there, and that's a central place to get access to all of the different rule sets for each of our expert panels. So to date in ClinVar, we have nearly 12,000 expert classified variants from our expert panels, and shown in this table are the many different variant discrepancies that have been resolved by the experts submitting to ClinVar. All the stats on the expert panels that are managed by ClinGen are in our evidence repo database, and you can go there and see the tallies of the number of variants that have been tackled by each of our expert panels that are approved. Some of them are still developing their rules and haven't yet submitted data as they're going through their validation, but all the summary of the data that is in its final stage is in the evidence repo. But when you look in ClinVar in particular, because all of these are submitted to ClinVar, this is where you'll see the expert panel tag that I showed you earlier for the hearing loss variant. And I think I mentioned that because this is a rigorous process that ClinGen goes through and we apply to the FDA for recognition of our variant classifications, they all have this tag, FDA recognized database. You can, in addition to the classification and which group made it, you'll see an evidence summary of all the detailed evidence that went into classifying that variant. There's also a link to our evidence repo where you can get access to the structured evidence with each code and the rationale for why it was or wasn't applied, all laid out in that evidence repo. Not all of that structured data fits into ClinVar, but there's a link to get to it if you want everything there is to be had for that variant. And then all of this work of classifying these variants is done in ClinGen's variant curation interface, shown here, where they have access to all the codes and the ability to apply them at different strengths and track all of the decisions that are made by the expert panels, as well as get access to data, population data, etc. that's either brought in an automated way or in some cases entered through publications, etc. And this platform is used by both our expert panels, but also individual laboratories and even individual clinicians will use this to classify variants. And there's going to be a breakout session tomorrow teaching you how to use the VCI if you're interested in doing that. I do want to mention that although we have a large focus on resolving variant classification discrepancies, we also work to classify VUSs that we think we might be able to move out of the VUS category. And this slide is an example from our cardiomyopathy expert panel where there were 7 variants in their first pilot set that they were able to move from uncertain up to pathogenic or likely pathogenic by aggregating evidence across different groups. So you can see originally this variant was uncertain significance by the 2 labs that had submitted on it, but later when the expert panel brought the evidence together, they were able to move it to likely pathogenic. So this is happening routinely, and there's a prioritization of variants where they may be VUS by everyone, but there's a lot of submissions on it that suggest there might be able to aggregate that data and move it to a different classification. So I will make sure I point out that the goal of our expert panels is not to classify every variant. We will never get through the over 800 million variants in the human genome. There's probably over billions of them. So we have to prioritize. We focus our priorities, as I've already alluded to, on resolving discrepancies in variant classification between labs that submit to ClinVar. We also want to make sure we've classified the most prevalent pathogenic variants that are seen in cases. And then, as I mentioned before, we examine those variants that have been observed in multiple cases through which combining data may move them from VUS or even from likely pathogenic to a more certain state of understanding. Now, as I mentioned, all of this work is largely done by volunteers and other experts who are willing to share their time and contribute to this collective curation of variant knowledge. And so I encourage all of you to participate. You can go to our website and there's information about how to get involved, even just to sign up for lists to hear talks from ClinGen, but you can also volunteer to curate for any of the groups and you'll be taught how to do that and you can participate. If you're an expert in a particular disease area, you can join one of our existing gene or variant curation expert panels as an expert. Or if there's not one in your field, you can also start a new one yourself and we can help you. And there'll be more information in one of the breakouts tomorrow around these expert panels, how they work, how they get started, things like that. And with that, I do want to just thank all the people that that contribute to this work. We have a steering committee that's made up of the 9 PIs of ClinGen and other members of the leadership of ClinGen. We also have many work groups that that lead all of the development of the approaches that we apply in ClinGen. So all of the work group co-chairs are listed here. We have an amazing set of ClinGen program coordinators that really just make the ship run. A very valuable external scientific panel that gives us guidance. Funding from NIH, particularly NHGRI, and then most importantly, as I mentioned, we have over 1,500 people from around the world that are contributing their time to help make this resource as valuable and rigorous as it is. So I'd just like to thank everyone and encourage you, if you're not involved yet, to get involved. We welcome your participation. Thank you.